is taking a much needed and well-deserved vacation, but he will return next week with our special guest host, Dr. Travis Vandergriff at UT Southwestern. Let me do a quick introduction of myself. My name is April McDonald, and I assist Dr. Davis on all of his educational initiatives here at Sagis. You've probably received a couple emails from me in the past. As always, if you have any questions, please feel free to reach out to us at education@sagisdx.com. We love to hear from you guys. Now, let me introduce to you our special guest host for today's happy hour, our very own Dr. Scott Dalton. Dr. Dalton is a double board certified dermatologist and dermatopathologist. He completed his dermatology residency at Geisinger Medical Center in Danville, Pennsylvania. He then went on to complete his dermatopathology fellowship at the University of California, San Francisco, under the direction of renowned dermatopathologist, Dr. Phil LeBois. So without further ado, let me introduce to you Dr. Scott Dalton. Dr. Dalton.
Good evening, everybody. My name is Dr. Scott Dalton. I'm a dermatopathologist for Sagis, and I'm going to be talking about cutaneous lymphomas this week for the happy hour. As you guys probably could tell, the slides were a little bit more difficult because they weren't obvious diagnoses, because they seem to be missing some things. With cutaneous lymphomas, a lot of times you have to have immunohistochemical stains and gene rearrangement studies. Before we get started, I do want to thank Dr. Tom Davis for, again, inviting me to give this talk. And this is probably one of the more difficult subject matter in dermatopathology for residents. And it turns out on a day-to-day basis, diagnosing lymphomas and especially in low-grade lymphomas, differentiating them from reactive conditions is a challenge on a day-to-day basis. But I think it's sort of important to go over these in detail, and sort of I can show you my approach on how I try to make the diagnosis. Fortunately, especially in the B cell side, there are more limited subtypes of cutaneous lymphoma. On the T cell type, there's many more, but again, as you'll see, the overwhelming number of them are Mycosis fungoides. And so I'm going to kind of go over my approach to making the diagnosis of cutaneous lymphoma, looking at H&E and then some immunohistochemical stains, which I won't have slides for the most part, but I'll show you, slides for. Sometimes this talk is better done as a PowerPoint, and so I sort of created some PowerPoint slides to help understand it. Okay, so I just have this slide up first to show that there's a multi-potential hematopoietic stem cell that divides into a myeloid precursor and a common lymphoid precursor. And of course, there's a section on myeloid tumors and macrophage tumors, and you can see sort of how this, what the lineage is. But on the common lymphoid progenitor side, it first splits to natural killer cells and then to the small lymphocyte. And during embryology, the small lymphocyte develops into T cells in the thymus and B cells in the bone marrow. And then, of course, at some point, they migrate to the lymph node, because that's kind of going to be our framework for understanding these. And then a B cell then further matures or goes through lineage changes in order to form the plasma cell. And remember that when they're in the thymus and B cells, they're, in the thymus and bone marrow, and then when they get to the lymph node, there's antigen presenting that's going on to differentiate self from non-self, and there's T cell receptor gene rearrangements and in the T cell, and then B cell heavy chain and light chain rearrangements to determine foreign versus self. Okay, so when we get to the lymph node, so in general pathology, most lymphomas are studied in the lymph node, and we have a framework to understand that because the lymph node has a capsule. that surrounds it. And then when lymphoma occurs in a lymph node, usually we lose the lymph node architecture, which makes us know, is this reactive or is this lymphoma? Because the entire lymph node will be replaced with abnormal lymphocytes. The structure of a lymph node is composed of primary follicles that mostly contain B cells. Those follicles can become secondary follicles or germinal centers, which is a reactive type of follicle. And there are T cells associated with lymphoid follicles, especially around the mantle zone. But the predominance of T cells are present in the paracortex. So, and then of course there's a capsule that surrounds it that stops, sort of keeps it contained. All right, so in the skin, it's a little bit different. So here we have, this is sort of a graphic representation of the basement membrane zone. And here we have capillaries, little arterioles and venules, as you know, that travel into the dermal papillae. There's a superficial plexus and a deep plexus when we're studying vasculitis, and then capillaries go down into the subcutis or the panniculus. And a lymphatic channel travels along with these blood vessels. And so nodular growth of lymphomas tend to occur superficial and deep in the panniculus, but then spread interstitial as they sort of overtake the dermis. Of course, there's no defined region here. It just can spread out throughout the entire dermis of the skin. Of course, clinically, you have a nodule or a plaque or something that it's sort of defined, kind of confined to. But it's hard to know, are we dealing with a reactive condition or a lymphomatous condition, again, especially when we're looking at smaller lymphocytes. So that's one sort of difference. The skin, or they call it SALT, skin-associated lymphoid tissue. All right, so let's dive further into a germinal center. So here's a typical germinal center. And so I want to go and look at the specific cells in the germinal center. And here we have, basically, this is based on an old working formulation when they called the cells based on their histopathology. And so we have non-cleaved cells and we have cleaved cells in a germinal center. And you can see the groove there. They have large cleaved, small cleaved, large non-cleaved, and small non-cleaved. And the non-cleaved cells are either immunoblasts or central blasts, and cleaved cells are central sites. So here's an actual photograph of central sites, and these are more typical in follicular lymphoma, which we'll go over. And so you can see that they're not perfectly cleaved like in that cartoon. However, there are irregular grooves. They're irregular shape, they're elongated. Sometimes they're even look like clovers. And then, because it's sort of normal lymphocytes are here on the right side of the screen, which are small and round. Okay, so these are cleaved cells. All right, these are so again, those were central sites. These are central blasts and immunoblasts. And immunoblasts are round with a central prominent nucleolus. They're kind of like, I think of them as cyclops cells. They have the eye sort of in the center. And then that's an immunoblast. And then central blasts have chromocenters. So like this is a good example where we have 3 nucleoli sort of pushed to the edge of the nuclear membrane, and there's some vesicular chromatin present. And these are more typically seen in leg type B-cell lymphomas. All right, so back to the germinal center. So these cells sort of compose this, and a normal germinal center in a lymph node, and even in skin, like when we see in lupus, has some polarity to it. What that means is there's darker cells at one end, it's usually more the immunoblasts, and lighter cells at the other end, which is more sometimes central sites, the cleaved cells. And then you can see all these spaces here are tingible modic macrophages, which are presenting antigen within this reactive germinal center. On the outside, we have what's called the mantle cell. We don't tend to see primary cutaneous mantle cell lymphoma, but we can get metastatic mantle cell lymphoma to the skin. All right, and then around this area, which is not really shown here, is because usually only in neoplastic senses do we see marginal zones. And excuse me, yeah, marginal zone lymphoma. So marginal cells are more round cells, and then oftentimes you'll see plasma cells present, especially in marginal zone lymphoma. Okay, so that was sort of a tour through the types of B cells. Now T cells tend to be more, I guess, more small centrocyte-like, a little more cleaved and irregular, and they tend to be hyperchromatic. But again, you know, depending on what type of T cell lymphoma you have, because since most of them tend to be epidermotropic, and B cells tend to be more nodular and diffuse. But again, as T cells get more aggressive, they tend to form nodules. So it's not perfect, but they tend to be more hyperchromatic and cleaved-like. All right, so that's sort of morphology, which I think is important. So again, from a conceptual standpoint, when you start looking at infiltrates of lymphocytes, you want to determine, are they large and small? And are they sort of nodular and diffuse? And is there involvement of the epidermis or not? So those are some basic morphologic things that you should be thinking about. Then the next most important thing is, what do they stain for? What types of markers will be positive? And so again, from a basic standpoint, T cells stain with CD2, CD3, CD4, CD8, oftentimes CD7, which are aberrantly staining, or loss of staining is common. So those are T cells. And then B cells are CD20, and sometimes we use CD99. So CD20 is kind of the key stain. But there's other stains like CD23, CD21. There's other cells, other immunos you could use. And then plasma cells are CD138. So you want to get a CD20 and a CD3 at least on these to figure out, is it B or T cell. And then there are other helpful stains that sort of help you differentiate when you sort of narrow it down. BCL2 is an important marker for aberrancy in B cell. BCL6 is important for germinal center. CD10 is important for germinal center. You know, CD30 is a huge one when they're large cells, to find out if it's a CD30 lymphoproliferative disorder. And again, we're going to go through all this. So CD68 is a histiocyte marker. So this is just a list for you. Okay. All right. So what are for B cell lymphomas, really there's three key lymphomas that we need to talk about. Primary cutaneous marginal zone lymphoma, primary cutaneous follicle center cell lymphoma, also known as follicular lymphoma, and primary cutaneous diffuse large B cell lymphoma. And leg type is often mentioned with that because they're common on the leg. I'll talk briefly about that, but that's a whole lecture within itself about where the leg type lymphoma came from. All right, so those are the three key ones. And as you can see from this study, one of the biggest studies from the Netherlands, Wilmsy is a famous dermatopathologist in the Netherlands. And the Netherlands have sort of a socialist type of healthcare system. So they have a great database that kind of follows these patients. And so marginal zone lymphomas comprise about 30%. Follicle center cell / follicular lymphomas comprise about 49%, so almost half. And then 20% are diffuse large B cell lymphoma leg type, or leg type not on the leg. All right, so those are the three key B. Now there's other B cell lymphomas, and of course there's metastasis from nodes to the skin. So we have to be thinking about these things. But the three main primary cutaneous B cell lymphomas are those. All right, and with T cell lymphoma, the overwhelming majority are mycosis fungoides. And then the second most common is primary cutaneous CD30 positive lymphoproliferative disorder, which is composed of cutaneous anaplastic large cell lymphoma and, of course, lymphomatoid papulosis. But other ones we'll see is subcutaneous panniculitic T-cell lymphoma, and this kind of newer entity called primary cutaneous CD4 positive small medium pleomorphic T-cell lymphoma. It's pretty indolent, and it's very difficult to differentiate this oftentimes from just a reactive condition like a bug bite, pseudolymphoma. And a lot of times positive gene rearrangement studies is the only way to sort of figure it out because it has a mixture of B and T cells. And then you can see some of the more aggressive and rare types of lymphomas. All right, so let's now move to the first case, and let's try our approach here. So first thing we note, again at low power, so there's a large excision, and we have a nodular proliferation of blue cells at low power. And although this may have been biopsied before, because I feel like we see a scar here, there doesn't appear to be much gravitation towards the overlying epidermis. And so it's, again, nodular proliferation. You can see these nodules here. So, are those reactive germinal centers, or are those neoplastic nodules? So let's hone in on the cell type. And again, it's good to get a good frame of reference. So an erythrocyte is 8 microns. And so some of these cells are a little bit larger, and some of these cells with more cytoplasm are significantly larger, and they have sort of irregular borders, cleaves, if you will, if you look around. And again, it's not a perfect science. Sometimes you'll see mixed immunoblasts and centroblasts also, and remember, there's lots of reactive T cells, and that's where it gets more confusing when you start doing the immunostains, because here's some small round ones, because the immune system's sort of fighting this neoplastic process off at the same time, because there's even an immunoblast there, the Cyclops one, but you're going to see those. But for the most part, these are kind of small and irregular cells. Okay, so to me, this is mostly composed of small cleaved type cells with a few larger cleaved cells. So these are centrocytes. So already I'm thinking, what's the one that has mostly centrocytes? Okay, then all of these cases require a lot of workup to figure them out. A lot of immunostains oftentimes. And again, we should get a CD3 and a CD20 to start with. And in this case, as you can see, the CD20 is diffusely positive. That is way more B cells that you should see in any reactive infiltrate. It's the overwhelming predominance. Mostly reactive conditions have less B and more T cells. All right, now here's some other markers that help us. So mostly B, and then you see that there's some CD10 present within some of these nodules. So the counter stain is you sort of have blue and lighter blue within immunohistochemical stains. You can see there's dark staining here in these nodules. Here we have BCL6 positive. That's a nuclear stain. You can't really make that out in this picture, but so the nodules are BCL6 positive. And here we can see that the nodules are negative for BCL2. But BCL2 is positive in between the nodules, because BCL2 is positive in normal reactive T cells. So there are tons of reactive T cells, but these nodules, which are not normal, because that's the other thing to talk about. Let me just go back to that slide and show you that. Remember when we talk about polarity in the germinal center? This is not a normal germinal center. There's no polarity here. The nodule is completely diffuse. So that's an abnormal finding also. That is not a germinal center. That is not a reactive germinal center. So these nodules are not germinal centers, and it's BCL2 negative. So this is follicular lymphoma. And this is usually follicular lymphomas present on the head and neck with a purple to red nodule. Okay, next case. All right, so this looks a little bit different. We have a superficial and deep proliferation of B cells. There does not appear to be overlying epidermis involvement. However, sometimes it does happen, but we don't see a lot of exocytosis of lymphocytes and a little bit of spongiosis here. So again, you're going to see some lymphocytes in spongiosis. Okay, so when we go to high power, so again, this is mostly diffuse and not nodular. And if we take a look at the cells, they are mostly large. So here's some small lymphocytes in the background. Here's an erythrocyte. So these are double, if not 3 times the size of an erythrocyte. And so that gives you a size reference. So these are large cells. And these large cells, there's mitoses here. That's not, I mean, although you can see mitoses in lymphocytes, that's not uncommon to see them all over the place. Here's one there, there's one there, there's one there. And here's a central blast that has chromocenters along the side. And let's see if we can find, should be immunoblasts in here also. There's an immunoblast here. There's an immunoblast, this is the cyclops cell. So this is a diffuse infiltrate composed of mostly central blasts and central sites. And so this is just a reminder, this is what central blasts and central sites look like, similar. Now we have to get immunohistochemical stains. And this is a CD20, so it's diffuse CD20 positivity. Here's a BCL2, so the cells are diffusely BCL2 positive. This is a marker we didn't talk about called MUM1. It's a nuclear stain. It's related to the MUM comes from multiple myeloma because MUM1 is also positive in plasma cells, multiple myeloma. However, it's also been found to be positive in this entity, which is called diffuse large B-cell lymphoma, MUM1 positive, and it's a leg type, diffuse large B-cell lymphoma leg type, more aggressive type of cutaneous B-cell lymphoma. Okay, let's move on to the next case. All right, so we have a superficial and deep, fairly nodular growth pattern again. No overlying epidermal involvement. Okay. All right, and there are diffuse areas, and then there's also some of these little nodules here present. And again, as I peruse this, I'm always thinking about, are these reactive germinal centers in the nodules? Is it just a diffuse, and then of course I have to figure out, what's the amount of B and T cells. So oftentimes it's like, okay, we got to get immunes on this one because we got to figure out what the cell types are. The whole bottom heavy versus top heavy thing that people learn, it doesn't always bore out in terms of what's cutaneous lymphoma versus lymphoma. That was sort of a traditional teaching. It sometimes can be helpful. But as we go and look at the cell type, there's lots of plasma cells here, and there's a bunch of small rounder lymphocytes. So again, you tend to see plasma cells more often in marginal zone lymphomas, and you see rounder cells because these aren't as cleaved as we saw in the follicular lymphoma. So we get an immunostain, and we see that CD20 is staining many nodules within this infiltrate. So that must mean all this other stuff is CD3 positive. So this one's heavily mixed. And then when we do a BCL2, BCL2 is sort of missing in these nodules. So that could mean that those are reactive germinal centers. And we know that this is BCL2 positive, but it's also CD20 positive. So when you have BCL2 co-expressed with CD20, that's aberrant staining. So that is a B-cell lymphoma, except for follicular, should be BCL2 positive because we just saw that in the leg type lymphoma. So this is a marginal zone lymphoma. All right, so that's the third lymphoma that we see. In marginal zone lymphoma is probably one of the most difficult to differentiate between a reactive process. And so, I showed you a few examples. Typically we do a kappa and lambda stain to look for clonality in the plasma cells. And oftentimes we have to do gene rearrangement studies to see if there's a heavy chain or light chain restriction. So, it's not just as simple as me slapping a CD20 and a BCL2 on it. You know, these take more extensive workups, but again, it's sort of beyond the scope of this sort of introduction to B-cell lymphomas. All right, so this is a nice chart that kind of helps for tests of knowledge. So we have, you know, follicular lymphoma, we have nodal lymphoma, we have primary cutaneous marginal zone lymphoma, and then some other smaller lymphomas that would be in this differential is mantle cell. Of course, that would be metastasizing from the node, so to speak, or extending from the node into the skin. And then B-cell chronic lymphocytic leukemia is commonly tested, mainly because it co-expresses the T-cell marker CD5 and then CD23, because they always want you to differentiate that from mantle cell lymphoma mainly because we see a lot of chronic lymphocytic leukemia around squamous cell carcinoma. Most surgeons run into that a lot, so they want you to sort of recognize it and differentiate it from mantle cell lymphoma. So this chart will be helpful. And one other thing to sort of talk about, because again, this is the big three. Anytime you have a patient that presents with these cutaneous lymphoid infiltrates and your pathologist is really worried that it's lymphoma, then you should have staging done. And I tend to refer them to a hematologist, oncologist. That way they can sort of do their workup, and then oftentimes they'll bounce it back to us. You can see that the 5-year survival rate of marginal zone lymphoma is 98%. The follicular lymphoma is about 90%, but the sort of bad actor in the B-cell lymphomas is leg type at 50%. And then there are a few bad actors of follicular lymphoma when they happen on the leg. And of course, there are non-leg types of diffuse large B-cell lymphoma that still have a poor prognosis. So these three have a poor prognosis. So it's just something to think about, that not every B-cell lymphoma is indolent. Okay, so let's move on. Let's take a look at the next case. All right, so we have a superficial and deep, well, in this case, it's hard to tell. I mean, to me, it looks like we have blood clots in the vessels. So are we dealing with a coagulopathy here? Because I see the thrombi here. So it's superficial and deep, because I think we also have some action going around in the mid plexus. Superficial plexus actually doesn't look too bad. You see some dilated line, but there are some hyperchromatic cells present here. And we go and look, and these blood vessels are packed full of large mononuclear cells. And while this is not a very common one, it's one that they love to test you on, so we need to go over this. So let's take a look. I do have an immunostain to show you that was scanned. All right, and so this is a CD20. Okay, and so you can see that they're, let's get to an area where you can really see the morphology. You can see these are large mononuclear cells that have membranous staining with CD20. So this is what we call intravascular B-cell lymphoma. Oftentimes these will present when we get a consult from hematology, oncology, they're concerned about it. Many times there won't be any histopathologic findings, and it turns out that you can do a random biopsy. But if you can biopsy a hemangioma, for some reason they gravitate towards just regular cherry hemangiomas. And if the patient has a lividoid pattern on their skin, then that's the best area to biopsy. But you know, this is sort of causing a coagulopathy, but full of neoplastic cells. All right, let's move to the next case. All right, again, we have a sort of mid-diffuse infiltrate of blue cells. That seems to be an overwhelming theme here, but that's why immunohistochemical stains are so vitally important. Again, not much epidermal involvement, so let's figure out what the cells are. And in this case, they have a bunch of cytoplasm, and there's perinuclear HOF next to it. It's kind of hard, we can't get high enough power, but they have a pinwheel nucleus. and they're eccentric. The nucleus is eccentrically placed, and so these are plasma cells. Now you have to be careful because some forms of marginal zone lymphomas can be plasmacytoid, and so you know, you do a CD138, but you also should do a CD99. CD20 won't stain these, but CD99 will, showing there is some B cell lineage, and CD138 and 38 should stain these. And then you get a Kaplan lambda, and that should be restricted. So this is a plasmacytoma, but just the only caveat is be careful because marginal zone lymphomas can be plasma cell rich. Okay. All right, so let's sort of shift gears and talk about T-cell lymphomas now. All right, and in my last lecture on interface dermatitis, I talked about T-cell lymphomas because they can be, since they tend to be more superficial and can have necrotic keratinocytes, especially mycosis fungoides with exocytosis of lymphocytes, the inflammatory dermatoses come more into play, especially in the early patch and plaque stage mycosis fungoides. So here we have a superficial perivascular infiltrate of somewhat irregular hyperchromatic lymphocytes. In the epidermis, we have hyperchromatic lymphocytes with vacuoles surrounding them, sort of tagging at the DEJ. Again, you can have a few necrotic keratinocytes, which makes it more difficult. We have what's papillary dermal fibrosis, and sometimes you'll see what's called the bare underbelly sign. A lot of these terms coined by Bernie Ackerman, and the fettuccine sign, which is the papillary dermal fibrosis. Bare underbelly sign is when the lymphocytes are gravitated more above the superficial plexus of vessels. So this is patch stage mycosis fungoides. And here's a clinical representation of that. This is the more hypopigmented variant. Now, just one thing about immunohistochemical stains with mycosis fungoides is they have somewhat of a role to sort of determine whether or not this is CD4 or CD8. And that triggered my memory because CD8 tends to be more hypopigmented from that clinical photo, and CD4 oftentimes are more erythematous and hyperpigmented. And so it's totally common for somebody to do a CD3, a CD4, a CD7, and a CD8, because supposedly CD7 will be lost in the epidermal cells because loss of markers in T-cell lymphomas is an aberrant. But I have to tell you, in practice, oftentimes it doesn't work out that way. So I find in mycosis fungoides, immunostains are less helpful other than sort of determining if it's a CD8 or CD4 predominant type. Of course, you can have double negative CD4 and CD8 and double positive. All right, so let's move on to the next case. All right, so here we have a superficial and deep perivascular infiltrate, and this actually has papillary dermal edema and extravasated erythrocytes. So lots of inflammatory things can come to mind here. But as we go to higher power, these lymphocytes don't look normal. They're extremely hyperchromatic, and there's way more exocytosis of lymphocytes than expected for the amount of spongiosis. And so that's more epidermotropism. Again, very hyperchromatic in the papillary dermis, and some even larger cells here. And so if we did on something like this, we do have to do immunohistochemical stains because more things than mycosis fungoides come into play here. We need to know if it's CD4 or CD8 because CD8 cells can be present in the more aggressive CD8 positive T-cell lymphoma. And there's a variant of lymphomatoid papulosis called LYP type D. I'm going to go over the different subtypes of LYP here in a minute, which is actually looks terrible, looks aggressive, but it's actually very indolent, but it will present like other forms of lymphomatoid papulosis, but which will come and go and spontaneously resolve. But it turns out that this is a plaque stage mycosis fungoides, which is what we see the typical prototypical involvement of plaque stage mycosis fungoides. And so when we go back to this, I mean, how did we determine it was plaque? Well, there's two ways. One is the epidermis is plaque-like, and the amount of lymphocytes are expanding the dermis, and so that's another reason it's plaque versus patch, where clinically it would be patch-like. So the distinct definition of plaque versus patch is not laid out in the literature perfectly. It's usually a combination of the epidermal acanthosis and the amount of lymphocytes. I just wanted to show you this. This was a patient of mine at Geisinger Medical Center she was pregnant at the time and had tumor stage mycosis fungoides. So MF can progress, and even though the majority are indolent and patients outlive them, when they become plaque and tumor stage mycosis fungoides, we have to get more aggressive in treatment. All right, next case, we have a superficial and deep, and this one's more periadnexal infiltrate, some follicular plugging, and when we look at the cells themselves, they're more hyperchromatic and somewhat irregular in shape, and then the follicle structures have some spongiosis and mucin present within them. And so once you see mucin within spongiotic areas, then you're dealing with something called follicular mucinosis. Follicular mucinosis is not a diagnosis per se, it's a pattern. And the first thing you should be thinking about is folliculotropic or follicular mucinosis mycosis fungoides. That doesn't mean it's going to be that, because there are some patients that have follicular mucinosis and have alopecia mucinosis and they don't develop mycosis fungoides, but you should, that's what needs to be worked up. And then oftentimes it'll be in an older adult that'll have these plaques. And so follicular mucinosis, on tests of knowledge, the question is, when you see something like that, do you outright call it mycosis fungoides, or do you call it follicular mucinosis? I think it's better to call it by its pattern, follicular mucinosis, and then make the diagnosis, do gene rearrangement studies, immunohistochemical stains, see if there's loss of markers for T cells. Of course, again, when you're working this up, there are follicular variants, of B-cell lymphomas, but they don't tend to show epidermotropism like this. So again, this is more likely a T-cell process than a B-cell process, just based on some of the things we've talked about. All right, next case. We have a superficial and deep infiltrate, kind of nodular and diffuse. All right, lots of spongiosis in the overlying epidermis. Let's look at the cell type, and we have large cells, and this one has a lot of eosinophils present, and that's something we haven't seen thus far, is a lot of eosinophils. Most of the B-cell lymphomas that we've talked about lack eosinophils. And you tend not to see eosinophils in patch and plaque stage mycosis fungoides, but in other more aggressive T-cell lymphomas, you can see a lot of eosinophils, and you can see that these cells are immunoblast looking, so large mononuclear cells. So we have to get stains, and CD3 is positive in this case. And then I also have another immunomarker that I want you to show, because this is important. Anytime something's CD3 positive and has large cells, then the next thing you should be doing is a CD30, very important stain in T-cell lymphomas. So again, these immunoblast-like cells have a what we call a membranous staining with CD30, and oftentimes they have a Golgi, what they call perinuclear Golgi dot, or paranuclear Golgi dot, and so quite a few cells here are CD30 positive. That's too many for a reactive condition like bug bites can have CD30. So this is lymphomatoid papulosis, or it's a CD30 lymphoproliferative disorder, and then you have to look at the clinical presentation. So if it's papules and nodules that come and go, then it might be type A, And if it's one large tumor, it might be type C. So let's go over the different variants of lymphomatoid papulosis. This is an older slide, but when there were only 4 variants, now there's 6. So LYP type A is sort of wedge-shaped with, they usually say up to 30% CD30 cells. Type B looks like Mycosis fungoides. And it doesn't tend to have a lot of CD30 cells, so it'll have epidermotropism. Type C is anaplastic large cell, or type C variant is kind of the anaplastic large cell variant. And then type D is that CD8 epidermotropic variant that I was telling you about when we were looking at the plaque stage MF. And type E is an angioinvasive variant. And then there's a new variant that's only determined by molecular, a 6p25 rearrangement, and that's really less than 5%. Really, type A is greater than 80% of the cases, and type C is about 10%, and the rest sort of fall within that. Okay. And so I was trying to sort of illustrate here. This looks, again, we have an epidermotropic proliferation where we have lots of exocytosis of lymphocytes. And so when you looked at it, you're like, well, this is Mycosis fungoides again. Well, I was just trying to illustrate that LYP type B can look just like this. And actually, LYP type D can look like this because that's another, but LYP type D would be CD8 positive, and usually LYP type B would be CD4 positive, just like Mycosis fungoides. So it has to be ones that come and go. So obviously, on every case, you have to have clinical, immunophenotype, and morphologic correlation in order to come up with the diagnosis. All right, so let's move on to the next case. All right, so we have more of a superficial infiltrate, superficial and mid, somewhat nodular, and a large excision specimen here. Okay, you might have also noted that there's some tattoo pigment within this, and so again, you're wondering, well, is this just a reactive tattoo pigment, pseudolymphoma, or could this be a lymphoma? So we go and look at the cells, and the cells are more round, but there's also a mixture of plasma cells. There's some eosinophils. So it seems like more like a mixed population. There's the tattoo pigment. So is this just a tattoo reaction, which can happen, although it's pretty diffuse? And so what's the next step? So they're mostly small. So is it B or is it T? See, there's even histiocytes here, which tends to be more seen in reactive conditions. So, all right, so again, we have to do a large panel of immunohistochemical stains. All right, and so this is a CD3 here on the left, top middle is CD4. So they're CD3 and CD4 positive. This is a CD8, so there's a lot less CD8. Now, some of these other immunostains here, oh, this is a CD20. So look, CD20 is less than CD4, but there are a ton of CD20 positive cells here. So is this a B-cell lymphoma, marginal zone that has a lot of T cells? This is PAX8, which is another B-cell marker we don't tend to use, and this is CD7. So we don't see a lot of aberrant loss of CD7. So now I'm sort of stuck, well, is this lymphoma or is this pseudolymphoma? And oftentimes when it's so you get T cell and B cell gene rearrangement sometimes, and there's a T cell clone here. So we have a small infiltrate of CD4 positive and CD3 positive T cells with a lot of B cells. So this is either reactive or this newer entity that I talked about earlier, which is called primary cutaneous CD4 small medium T cell lymphoproliferative disorder. Some people even argue in the literature that this is a reactive condition, but when it has a positive clone, then it most likely is an indolent T cell lymphoma. So this is sort of more on the indolent side, like we see in marginal zone lymphoma. I feel like I see this more often in younger patients where they get this big nodule, on their nose, and then you biopsy and it has all these lymphocytes. So is it reactive, or is it lymphoproliferative disorder? Sometimes just injecting with Kenalog or doing superficial radiation can get can get rid of it. Oftentimes when they're not on the face, clinicians will excise them. But this one's kind of a more difficult one because you know, the differentiating between reactive and lymphoma is more difficult. Okay, all right, so next case. So this time, this looks more like a panniculitis. In fact, there's a large vessel here that doesn't look normal. So when we're evaluating panniculitides, we're trying to determine, is it septal or lobular? And a lot of the action seems to be going on in the lobules here. It's very important, again, still to look at the entire case. There's no epidermotropism. There is inflammation in the dermis, but most of the action is in the panniculus. And it seems to be mostly a lobular panniculitis. And of course, since we're doing this chapter on lymphomas, we have lymphocytes that are rimming fat. And so we have to be worried about panniculitic T-cell lymphoma. The differential, of course, is lupus panniculitis. And of course, there's a gamma delta lymphoma that also involves the panniculus. So those are sort of like the three things we should be thinking about when we see lobular panniculitis that is mostly made out of lymphocytes. The the CD8 positive panniculitic T-cell lymphoma, lupus panniculitis, and gamma delta. All right, and so if these are CD8 positive and there's some other markers we haven't talked about like granzyme and TIA, those are often positive in this. And so this is an example of the panniculitic T-cell lymphoma. Again, clinically, they can present just like any other panniculitis, so that doesn't help, and so a biopsy is very important. I just wanted to show you this for comparison's sake, because this is a lupus panniculitis. Here we have more lymphoid aggregates, and if you look, there's even germinal center formation, although they're not polarized like we saw on the true follicles. But again, these nodules would be CD20 positive because you tend to get more B cells present in lupus panniculitis, and also we have a hyalinization present that you see in lupus panniculitis. And also the other thing that's helpful, although I don't see it in this case, is when you get other prototypical features of lupus, that will help you differentiate it. There, in the literature, there have been some cases of overlap between lupus panniculitis and subcutaneous panniculitic T-cell lymphoma. So I think more is going to come out on that. I think out of UCSF, they had a paper, and out of Gratz, Lorenzo Cironi looked at that. So just for comparison's sake, another helpful marker is you tend to get CD123 positive dendritic cells in lupus that you don't see in panniculitic T-cell lymphoma. All right, and then our last case today, it's kind of been a whirlwind, but at least hopefully you have a better understanding. Here we have a superficial and mid-infiltrate perivascular, and when we look, these are large cells. These, though, tend to be less like, I mean, they're kind of like immunoblasts, but they're blastic in general looking. And of course, when you go over the cutaneous leukemias, you might talk about more about blasts and things like that. And so, but you get a CD3 and they're positive, and then you get a CD56 and they're positive. And so this is an NK cell lymphoma. And I just thought I would mention that. I haven't really seen many of these in real life in my now 15-year career. But when you get a midline granuloma like this, you need to be thinking about that. Of course, there are other lymphomas that can present this way. So again, you have to do a large panel to sort of figure this out. So again, this is an NK cell lymphoma. All right, so sort of to summarize, I think the most important thing to do is, pattern analysis like we always do. Is it superficial and deep? Does it involve the panniculus? are they nodular or diffuse? Then go down and look at the cells. Are they small or large? Are they cleaved around? Get some immunohistochemical stains. And for your board exams, you're going to have to kind of learn what markers kind of go with what. And then you all try to piece it together. And then knowing what the most common lymphomas are in the B cell and the most common T cell, you should be able to come up with a good differential diagnosis. So thank you all for joining, and we'll see you next time.